All right, guys, well, welcome to this pharmacology drug class review in the area of anti-lipemics or lipid-lowering drugs that we're specifically going to be targeting the LDL, okay? This topic is going to be about cholesterol absorption inhibitors, specifically, obviously, ezetimibe. Now, in this session, I'm going to explain why cholesterol absorption inhibitors matter in a way that is easy to understand, but also clinically relevant in this patient population who likely needs additional LDL lowering, okay? All right, guys, I'm Dr. Busti, and thank you for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind pharmacology and the drugs that we use every day, because when you understand the why, it makes the how easier. This is where mechanisms start to predict therapeutic effects, side effects, drug interactions, contraindications, monitoring parameters, and give us our counseling points. Now, with all of my drug class reviews, I cover and start off first with the core content. What agents make up this class? Thankfully, it's one. It's easy. But we have combination therapy that's worth considering. What are its common indications and uses in clinical practice? What is the overall net benefit? What is the pharmacology, actual mechanisms, pharmacokinetics, pharmacodynamic effects that then translate and help us to understand some of the clinical knowledge and application. And then, of course, we'll wrap it up, okay? So with that, let's talk about the agents. So ezetimibe, also known as Zetia, been around for a while, okay? So it has history, but the class has really not grown. So part of that is due to maybe not such a huge benefit, but still carries value that's important for you to know clinically. Now, it does come in combination with other drug therapy. Remember, you're going to see here, this is many times used as an adjunct, add-on. So used with bempedoic acid formulation, the two together make it easier for adherence compliance. Same thing with rosuvastatin and simvastatin, okay? And so, again, the purpose of combination dosage form therapies is purely for the purpose of improving compliance and adherence and getting those patients to their LDL goals. So those would be worth noting, okay? Now, as we move next into what are the common indications and uses of this particular drug class in clinical practice? And it's important to recognize that as it relates to a genetic cause for LDL elevations, heterozygous familial hyperlipidemia or hypercholesterolemia, and homozygous, HO, familial hyperlipidemia. Those two patient populations have a genetic predisposition to higher LDL concentrations because their inability to extract the LDL out of the vasculature. They have problems with their LDL receptors, okay? And so those patients are very difficult. So any drugs that we can use to get that LDL down, especially even if it's combination, will help these difficult patients, okay? Homozygous Sitosterolemia, right? That's another one. Primary or mixed dyslipidemia or hyperlipidemia for primary and or secondary prevention of atherosclerotic cardiovascular disease, okay? So a number of indications and uses that make it valuable and helpful in clinical practice. Now, let's move over and shift to what is the net overall benefit of this drug in use in clinical practice. I mentioned it a minute ago that it's commonly used in combination with other lipid-lowering drugs, specifically statins. If you saw, again, going back to the dosage formulations that come with combined, you saw statins there. You also saw the ACL inhibitor, bempedoic acid, which basically works in the same pathway of cholesterol biosynthesis that the statins do, just higher up or before HMG-CoA reductase. But the benefit here is that we can add on ezetimibe, okay, to statin therapy and get an additional 20% roughly of LDL reductions in patients who are on either maximum tolerated statins or who, just they're on other lipid-lowering drugs and that's all they can take, right? All right, now let's move into the mechanism, pharmacology. How does this drug work once it gets inside of the body or you administer it? Now, it is an orally administered medication. So what happens when you do that? All right, I'm going to point you to my anti-lipemic agent summary table that is available for you for free. Download it, thisiswhy.health. Okay, that link is provided to you in the description of the episode. If you're watching this on YouTube, if you're on our podcast channels, it's available there for you to be able to access that. Because I realize, for those of you watching the video, it is harder to see and or read. But I'll walk you through the basic components. So what I try to do is break them down into the target area. So LDLs that are lowering drugs that are statins, LDL targeting drugs that are non-statins, drugs that target the triglycerides, and then drugs that are kind of miscellaneous, hits multiple things like niacin. Where we are located right now are in the LDL target non-statin columns, and specifically in the cholesterol absorption inhibitor. Ezetimibe, it's one agent, but again, it comes in multiple dosage forms that allows it to be administered. Now you see here it says inhibits intestinal cholesterol absorption. So that's why it's called a cholesterol absorption inhibitor. But really what it's working on, and we'll see that here in a second, is that it's working on Niemann-Pick C1-like peptide, okay? NPC1L1, okay? Yeah, I know. It's much easier to say cholesterol absorption inhibitor, isn't it? But Niemann-Pick C1-like peptide is technically where the drug is working. Now, the target, we're in the LDL target. So the last two columns in this table represent, the first one is what is the primary target, which in this case is LDL. And again, we'll get about 20%. But then what effects do we have on other lipid parameters, things like triglycerides or HDL? And you can see that triglycerides might drop about 10%, and HDL may be raised by about 5%. So those are positive directions. Nothing weird is happening with the use of this drug. So you're just getting that really predominantly isolated LDL lowering. Now, why do I offer tables like this? So that you can learn a drug in a drug class at a snapshot level, right, compared to other drugs in the category of anti-lipemics or lipid-lowering drugs, so that you can start to get an idea of, okay, this drug class and that drug agent typically work in this target, and wow, it does better. So you see like statins, for example, if you really need LDL lowering over 50%, the statins are going to be able to do that. Small interfering RNA are going to be able to do that. And then, of course, moving to like drugs like your PCSK9 inhibitors. So that's important for you to know. And then, like you guys might say, well, then why do I pick statins over the other ones? Well, then it comes down to cost or dosage formulation, side effects, drug interactions. That's pharmacotherapy, isn't it? Okay, now the guidelines give us guidance as to which ones to use, and historically statins have been very commonly first-line agents based on evidence as well as the guideline recommendations. But that's what this table is trying to provide you. So this is the point where we're going to dive into the lumen where cholesterol is being absorbed. So when we eat food, obviously, it goes into our stomach and then enters the small intestine. And once it enters in the small intestine at this point, right, we have to get it in and across the enterocyte over into the portal circulation that's going to go back to the liver over here and feed the liver with its components and the nutrients and then process and do other things. As we bring that fat and food in, our body digests it, right? So we have bile that contributes to that, pancreatic enzymes, the acid in our stomach, all contribute to the digestive process to break them down in those essential components. So as that breaks down and we break down the dietary and biliary cholesterol, it has to get across and through the cell membranes of the enterocyte of that intestine, where then it can be processed and packaged and eventually kicked out as ApoB48 containing chylomicrons. Again, those chylomicrons are going to go up through the portal circulation to the liver. Well, the liver will extract it out. So in the middle of this enterocyte, you see cholesterol that came from that dietary component. The way that it gets through there is through a process by Niemann-Pick C1-like peptide, and that's right here on the luminal side of the enterocyte. And that's exactly where the cholesterol absorption inhibitor ezetimibe, or also known as Zetia, is blocking cholesterol absorption. Now, Niemann-Pick C1-like peptide, like I said before, is just hard to say. So cholesterol absorption inhibitor is going to reduce the amount of cholesterol making it into this location. Obviously, it will then stay in the lumen of the GI tract. But that also then reduces the amount of cholesterol going back to the liver. And when that happens, it can obviously have other effects. And we're going to look at that here. Okay, now once it gets inside the portal circulation, now it's going to the liver. And if we were to zoom in on a spot in the liver, we would be seeing the hepatocytes. And there's a lot of things happening inside of an hepatocyte. And you can see there's a lot of drug targets inside there, okay? Various enzymes and pathways that are targeting different lipid parameters. Lipoprotein little a. We got LDL receptors. We got cholesterol biosynthesis. I mean, it's complicated. I didn't create all this. I created the image. But I'm sorry, I'm just a messenger here, right? But you need to understand in this large class of drugs that we have in the category of antilipemics, it's important to see where they work. All right, so drugs like, remember I told you ezetimibe would be used in combination with bempedoic acid, which is our ACL inhibitor, ATP citrate lyase inhibitors. Be used in combination with our statin therapies because those are blocking HMG-CoA reductase, which facilitate cholesterol biosynthesis inside of the hepatocyte. All right, now listen guys. Anything that decreases cholesterol delivery to the liver or the reduction of cholesterol biosynthesis inside the liver is going to cause an upregulation of LDL receptors. And that's over here in this area where we have genes get turned on, we pump out and we produce more LDL receptors. Why would we do that? Well, because they will extract out LDL from the circulation that's coming by through the vasculature. And we want to do that because we don't want that LDL particle staying in the vasculature to deposit. So drugs like cholesterol absorption inhibitors, while they are primarily working in the intestine, will reduce the amount of cholesterol being delivered back to the liver through the portal circulation. That reduces the intrahepatic concentrations of cholesterol. That causes an upregulation of LDL receptors that will pull in LDL out of circulation, even in the context of someone taking a statin or an ACL inhibitor, okay, like bempedoic acid. So I wanted to convey that to you because sometimes we learn a mechanism of action and we only look at the exact target of where it works, but we don't consider the totality of the effect or the mechanism and why we get the additional LDL. That makes sense why it works the way it works, okay? It's also a great opportunity for exam writers to trick people who don't really know the drug, because they'll target certain mechanisms and there's technically 3 or 4 ways to convey the mechanism. And if you've only been taught one way or you only memorized it one way, there's a high risk that you'll miss it on an exam. And that's why I also spend the time trying to connect the collective dots, because you start to see a theme. Even if you study, like you'll see the same thing with statins or HMG-CoA reductase. You reduce the intrahepatic concentration of cholesterol, guess what? You're going to have the upregulation of LDL receptors. Any drug that does that is going to likely stimulate that indirect effect and contribute to the overall reason why it's a target for that lipid parameter, okay? And so I apologize for spending a lot of time beating that up a little bit, but I've done this long enough. I've done lipidology for years, part of the National Lipid Association for years. It's a great organization for those of you that are interested in cholesterol and lipid biosynthesis. I mean, it's a huge area, and we need a lot of good clinicians out there to understand how to not only interpret lipid profiles, but also how to manage these patients so that we reduce the risk of vascular disease. And it's not just heart, right? It's also peripheral vascular disease, also brain, strokes, and things like that, okay? All right, now ezetimibe is a prodrug. It gets rapidly converted to an active glucuronide. So prodrugs by themselves chemically don't do much or do anything, but when they get converted to the active form, they exert the pharmacologic effect. Now, that is done by UGT 1A1, 1A3, and 2B15. Now, remember, UGT, okay, glucuronidation, is a conjugative pathway. It's a phase 2 metabolic pathway of drug metabolism. Why would that happen? Well, it's predominantly done by the liver, and it's meant to make the molecule more hydrophilic by putting a conjugate on there. And glucuronide conjugates are more lipophilic in that reason. So, I'm sorry, hydrophilic, sorry. Now, in doing that, the glucuronide metabolite, okay, gets spit out into the bile. That's how it gets in part works. It undergoes enterohepatic recirculation. So you take it by mouth, it gets metabolized, it goes in the liver by the liver then kicks it back out into the bile, and it blocks that Niemann-Pick C1-like peptide in the lumen of the intestine to prevent cholesterol absorption. And so then it just gets reabsorbed. And so guess what? That glucuronide metabolite has a very long half-life in the body. And that's why you can administer not only once a day, quite honestly, you could probably get away dosing it every other day and still continue to get therapeutic effects, okay? So it's important to recognize that. Now, how does it get spit out, into the bile? Well, that's transporters. And there are OATP transporters, MRP transporters, P-glycoprotein, which is an efflux cell membrane transporter that moves, especially hydrophilic molecules, in and across cell membranes. Remember, cell membranes are lipid-loving. So only hydrophobic or lipid-loving molecules are going to make it through cell membranes that are lipophilic for that reason. Okay, now we're going to pivot and move over to our clinical knowledge, okay, and that application. I've already kind of been introducing some of those things. We're just going to continue to add on to it the practical application in clinical practice. So the first thing is it's add-on therapy, okay? Remember, it's a key adjunct to statins, whether that's because you hit the dose that's the maximum dose, or you hit the maximum tolerated dose, the patient's developing muscle aches, whatever, right? Or you got them on the maximum dose and they still haven't achieved their LDL goals by the guidelines, and you want to really reduce that risk of major adverse cardiovascular events and mortality. And so when you look at the overall potential benefit on mortality, I say potential because there is debate in the evidence, okay, in the literature about that. The estimated number needed to treat to get about a 2% absolute risk reduction is around 50. That means you have to treat 50 patients on ezetimibe, okay, in order to achieve that 2% potential in one patient. Okay, who's that patient? I don't know, right? But that's what it boils down to. When you compare that to other lipid-lowering drugs that are out there, some that are very expensive, those that are parenterally administered, sometimes infused, those are these sort of designer drugs that are, they're very effective, but they cost. And so when you're starting to decide what can I do, or maybe the patient's insurance policy will not cover it until they've failed or tried one of these other drugs like this, it makes it relevant. And so when you look at some of the data and you do number needed to treat, that's why we use number needed to treat. How much is it going to cost us in the system in order for one patient to benefit? Or before a patient gets harmed, because that costs the system too, doesn't it? And so we want low number needed to treat. Okay? These are still high, 50, 67. We're just splitting hairs here a little bit. These are not absolutes, right? Because we are drawing off of making inference from data. So we're extrapolating external application of internally valid information, right? So it's not perfect. But that gives you an idea. But for number needed to treat, we want that number to be low. Ideally less than 10 if you can get it there, right? Every few patients that I give this drug to, someone's going to benefit. And you want number needed to harm to be very high. I have to treat a whole bunch of patients for one person to have some bad outcome, okay? Now moving on to other places in therapy, these are the very high-risk patients. This has to do with our risk stratification when we're doing assessments for ASCVD, right? And those patients who need LDLs that are much more reduced or tight. That LDL target's typically less than 70 in milligrams per deciliter. That would be another place where it's hard to sometimes get patients down that low. How about severe primary hypercholesterolemia? Again, these patients who have significant elevations in LDL and they are not able to achieve, right, 50% reduction, even on high potency high potency statin therapies like rosuvastatin and atorvastatin therapies, then that's where you would obviously try to add on this agent, or use without a statin in patients who just cannot tolerate them, whether it's most likely from myalgias, myositis, right? Very rarely is it for liver unless, again, they're having dose-dependent or concentration-dependent problems, maybe from a drug interaction. Then this would be one of those options where we would use it even as a standalone option in patients where nothing else is available or working. Now, what about drug interactions? So cyclosporine, so this would be relevant in patients with organ transplantation in particular. We know that many times the drugs that are used for organ transplantation can cause dyslipidemia. And so that we need, and those drugs can interact with statin therapy. And so drugs that we can use, maybe that's the reason we would pick this drug class over a statin, or the dose of the statin is so limited because of the risk of drug interaction that we have to add on something else. So cyclosporine increases are known, have been seen, and this is mostly due to the fact of the glucuronide in part, okay? So when you see it says here, ezetimibe may increase cyclosporine by about 15%. Now, cyclosporine is an immunosuppressive drug, right? It's controlling our immune system so that we don't reject the organ in particular. Now, the issue that is happening is also interaction in part at the P-glycoprotein. Remember, they use that transporter in part for that. Glucuronides in particular are not necessarily the absolute problem, in all cases. But you look at phase 1 and phase 2, this is a phase 1 metabolic pathway, and phase 2 would be that glucuronidation pathway, and then of course then we have transporters. And so in these two cases, that's where it's contributing to it. But at the end of the day, while this drug interaction does happen, it does not seem to compromise the overall tolerability or safety use in patient care. All right, now moving on to what about fibrates? So fibrates or fibric acid derivatives like fenofibrate, gemfibrozil, okay, are typically used in patients with high triglycerides. So fibrate, when combined with ezetimibe, may increase the risk of myopathy and cholelithiasis, so gallstone formation. Why would that happen? Well, we know that fibrates, in part, okay, are known to increase the concentration of cholesterol in the bile. When you increase the cholesterol concentration in the bile, that cholesterol can precipitate. and in that precipitation can form stones over time. Now, if the gallbladder's been removed, you have a cholecystectomy, that's not likely going to be a problem. Now, in this particular issue of concern, this can happen with any of the fibrates, gemfibrozil or fenofibrate. Both of them have been known to do this, although gemfibrozil is worse. So fenofibrate doesn't seem to have as much of a problem. Now, gemfibrozil is known to increase the concentrations of ezetimibe. That may increase some of the myopathy there. It's hard to fully know which one, right? Because gemfibrozil is known to do that, and then you have this gemfibrozil affects glucuronidation as well, and so when you have ezetimibe being increased at some level, then it's a problem. I mean, gemfibrozil is known to affect the glucuronidation of statin therapies and caused clinically relevant drug-drug interactions, which then cause dose limitations of the statins in particular. So when you use fibrates and ezetimibe, they do increase the cholesterol excretion in that bile, and that can theoretically then raise the risk of cholelithiasis due to that precipitation inside the bile. So just keep that in mind. Again, if the patient has cholecystitis, I'm sorry, not cholecystitis, cholecystectomy. Cholecystitis is inflammation, infection of the gallbladder. If they've had cholecystectomy, right, then it's not as relevant, right? Keep your words straight as well, all right? All right, so overall, ezetimibe is very well tolerated, dosed once a day. I'm mentioning some of these side effects, but quite honestly, they're very limited. Okay, I'm not saying they're non-existent, they're just limited. You're also mixing them with other drugs that are known to cause myopathies, and so therefore it is hard to sometimes to know, because statins are clearly known to be a culprit, and it's a dose concentration dependent effect. So post-marketing adverse effects that have been observed, okay, liver injury. Now, again, part of the patient population that you're using this in already has typically fatty liver. So that's just a confounder to keep in mind. You are using them in combination with statins, and if the statin had an elevation in its concentrations, that's where the risk of statin-induced liver toxicity occurs, not in everyday general practice. Statins are actually very safe on the liver. So these side effects down here, again, are post-marketing reports, things. It's hard to prove without a shadow of a doubt what is the actual cause, but you know, if somebody has started a medication and started experiencing, you know, an unusual rash or manifestation systemically of something, then you put it together with the timing. And that's why it's important for somebody to be overall in charge of managing these patients and knowing what's going on. Now, what about monitoring? Well, it's straightforward. You should get a baseline lipid profile and then periodically assess it. You need probably a couple weeks, at minimum 4, to compare the effect. But generally the true steady state in that patient's lifestyle is going to be around that 8 to 12 week window. And then of course, once you've achieved the known effect, or if you've already achieved the goal, then periodically thereafter is appropriate. Liver function test, again, these patients already seem to have risk factors that would put them at greater risk for fatty liver disease, although reducing enterohepatic cholesterol biosynthesis and concentrations improves that. So it's a good thing, right? And that's why we use statins and these drugs in these patient populations. But clearly, no drug is perfect. There's always a risk or a side effect in these medications that you have to keep in mind. Now, I do want to close here in the clinical application on HIV patients, because you know, we talked about drug interactions with cyclosporine and the statins and issues like that, and trying to really hone in on the ones that probably are going to be relevant. HIV has historically been known to be a patient population in their drug antiretroviral therapies, specifically protease inhibitor-based antiretroviral therapies, can be known to cause very clinically relevant drug-drug interactions, especially with patients receiving statin or HMG CoA reductase therapies. And so ezetimibe was studied. I was one of the investigators in a multi-center trial looking at this in patients with HIV because they were very difficult to treat, especially when you have drug interactions and dose limitations on the drugs that you can use. And what we found is that you get a very similar additional LDL lowering effect in patients already on lipid lowering therapy without compromising their HIV management overall. And now these were specifically patients on PI or protease inhibitor based therapies in particular. So you can safely use ezetimibe in HIV patients, specifically on NNRTI and PI-based regimens without significant compromise to the patient's overall viral load or tolerability, right? That's what we wanted to make sure, because we don't want someone, these drugs are known to worsen lipids in them, but they also control the HIV. And so we don't want to cause, we've protected them from the complications of HIV, but now they die from vascular disease. So it becomes very difficult for these patients many times to take that many medicines. Okay, so remember, in summary, this is the cholesterol absorption inhibitor, specifically ezetimibe, also known as Zetia. It comes in combination with other drug therapy that's very helpful with adherence and compliance, but it's focusing itself and its mechanism on Niemann-Pick C1-like peptide, or the cholesterol absorption inhibition. Indications, remember, homozygous and heterozygous hypercholesterolemia. Also, Sitosterolemia. And then lastly, patients with primary dyslipidemia. Okay, so that gives us a lot of options. From a side effect standpoint, fairly well tolerated. That's nice. Some of the things I was trying to talk about are the kind of the nuances, the talking points sometimes gets more attention, but the overall risk of things like liver enzymes, elevations, and myopathy are really low overall in most patients. Now, where it shows up are in those drug combinations, like with the Fibrates or statins. And then lastly, one of the clinical pearls that's relevant is that this is easy to administer. It's once a day. Remember, it gets glucuronide, undergoes hepatic recirculation, fairly well tolerated, very little drug interactions, and the drug interactions that are there are not that bad. I'm not saying non-existent, but just not that bad. That makes it useful, guys, in real-world clinical practice. So I hope that you found it helpful to understand where this drug, in particular in a drug class, fits as an adjunct to the overall management of dyslipidemia, especially when you're trying to get patients to their LDL goal. Thank you so much for joining me, and I appreciate the fact that you are investing in your knowledge and understanding the why behind the things that you do. I'm Dr. Busti, and we'll see you next time.